So continuing the previous year NEET questions, 2025. So we will discuss this question from the last line. What is the next best step in management? So I think we'll be given a case and we have to come to the diagnosis and think of the next step. It's not the best step, it's the next best step. So please understand the question. So a patient with known history of bronchial asthma is currently on salbutamol and ipratropium pressurized meter dose inhaler. He now has nocturnal worsening of symptoms and frequent nighttime awakening. So straight away they are given it's a case of bronchial asthma. It is uncontrolled. With the current medication regimen, what is the next best step in management? So you know that salbutamol is a SABA. That is, it is a short-acting beta agonist. So a short-acting beta agonist causes bronchodilation. And ipratropium is a SAMA. That is, it is a short-acting muscarinic antagonist. So this also causes bronchodilation. Just a recap of basic physiology. Beta agonist is a sympathetic nervous system receptor. So when we are activating the sympathetic system, there will be bronchodilation. Muscarinic is a part of the parasympathetic system. And when we are opposing the parasympathetic system, there will be bronchodilation. Ipratropium and salbutamol both are short-acting agonists. So a patient with bronchial asthma is on 2 short-acting meter dose inhaler, but still he has worsening symptoms. Remember, in asthma, nighttime symptom is significant. Even if there is one night symptom, it means asthma is persistent or asthma is significant, right? So what is the next best step in management? So in asthma or COPD, there is something called step therapy. That is, when you are giving a particular regimen for the patient, if it is not working, we are supposed to add another drug. Even if that is not working, we are supposed to add the next step. So this question basically asks what is the next step in management. So we will discuss the options. Increase the dose of salbutamol. We should understand 2 terms when treating asthma. The terms are reliever and controller. Reliever is a drug which only relieves symptoms, or it's only short-term relief. It doesn't change the pathology. Controller is a drug which controls the disease activity. So it changes the disease activity. Like in rheumatoid arthritis, giving paracetamol or a NSAID is only going to relieve the symptom, but it does not change the inflammatory pathology. Whereas giving drugs like DMARDs, disease-modifying anti-rheumatoid drugs, is going to change the pathology. Likewise, in asthma, reliever only reduces the symptoms, whereas controller changes the pathology. So among relievers, we have 4. SABA, SAMA, LABA and LAMA. SABA is short-acting beta agonist, example salbutamol. SAMA is a short-acting muscarinic antagonist, that is ipratropium. LABA is a long-acting beta agonist. So we have more among this. Remember one name, formoterol or salmeterol. LAMA is long-acting muscarinic antagonist. Example is tiotropium, humeclidium, glycopyrronium. So even though the names are so complicated, they just cause bronchodilation, either in the short run or in the long term. So it just causes bronchodilation and reduces the symptoms. What is more important is only the controller. So the example for controller is ICS, which is inhaled corticosteroid. So ICS is the controller and SABA, SAMA, LABA and LAMA are the relievers. In bronchial asthma, this is the ICS is the pathology changing drug. So the current trend is there is no actual standalone benefit for reliever drugs. Even mildest case of asthma should have inhaled corticosteroids. So this patient was actually receiving a wrong treatment. He was getting only the reliever drugs, but controller drug was not even added. So he has no relief with SABA and SAMA. So we will discuss the options now. So increase the dose of salbutamol. I think it won't be that much beneficial because salbutamol is again a short-acting beta agonist. It's only a reliever drug. It may not help that much. Start LABA and inhale corticosteroids. Seems a reasonable option because inhaled corticosteroid is a controller and LABA is a better reliever because it has longer duration of action, so it may be better than SABA. Theophylline, Montelukast, both are oral drugs. They come in the step therapy, but they come later in the step therapy. So like it comes like the last step when these do not act. So from the option, I think B is reasonable and B is the answer. This is a flow chart from JINA 2026 guidelines. JINA is an association which in every year publishes guidelines on bronchial asthma. GOLD is an association which publishes guidelines on COPD every year. So based on this guideline, see this is the step therapy. Even the mildest case of asthma, the first step will have inhaled corticosteroid and a long-acting beta agonist. We discussed formoterol is a long-acting beta agonist. That is the first step. When that does not work, we go to the next step. So we increase the dose. Like initial step will be as needed inhaler. Next will be a daily maintenance inhaler. The next step will be increasing the dose from low dose to medium dose. And see the last steps will be adding other drugs like interleukin 4 receptor antagonist, etc. We will not discuss that. So just to know what is controller, reliever and what is step therapy.